Today's symposium for the Australian and New Zealand Society for Sarcopenia and Frailty Research. My name is Dr. Jennifer Jones, and I am the Early Mid-Career Researcher and Clinician Committee Chair, and I'm also the President-elect of the Society. It's a great pleasure to welcome you to this event, and we thank you very much for attending. These opportunities are an excellent time to network and to make connections within the society. As we know, the frailty and sarcopenia world is small, and we already have lots of connections. And then from these collaborations and connecting with each other, we can achieve incredible things together. I will now introduce the EMCR committee. So we have a fantastic group of committee members, and Dr. Anuha Gandam will be the committee chair from next year. And as you can see, all of the committee members are here on the slide. And the purpose of the Early Mid-Career Researchers and Clinicians Committee is to promote, support and engage with as many early and mid-career researchers and clinicians as possible to shape the future generation of sarcopenia and frailty research. In terms of what we have achieved this year, we had our first joint symposium at the Asian Conference for Frailty and Sarcopenia. So this was a joint symposium with the Asian Association for Frailty and Sarcopenia. And this was in October this year in Kaohsiung, Taiwan. And this is an excellent collaboration between our two societies. And from this international reach, we can really work together to achieve incredible things for improving the outcomes for our patients. We also had our World Sarcopenia Day, and as you know, World Sarcopenia Day is on July 4th. And this year we had a collaboration with the Sri Ramachandra Institute in India. And this webinar was very well attended. We had over 300 registrations, and we heard from a host of speakers across these two societies. And it was a really excellent event that really showcased the important work that we've been doing all the way across basic science and clinical research, and then also in translation into practice. So these are really rich collaborations, and having international reach is a fantastic deliverable from our work with the society. So you may be interested in joining the EMCR committee, and to be on the EMCR committee, you'd need to be a current member of the society. Our definition of an early and mid-career researcher or clinician is that you've completed your formal training, so that's it's your qualification, whether it be in research or as a health professional, within the last 12 years, and each committee term is 2 years. So if you are interested in joining the committee, we're very happy to hear from you, and we have our email shown on the slide there. If you're interested in joining the society itself, we have a promotion offer at the moment where you can get 15% off membership. Bear in mind that there are different membership categories, and full membership fees are $100, but there are different categories for different levels of membership. And some of the benefits of being a member is the attendance at symposiums and webinars, and also that opportunity to network. I can speak for myself that joining from the committee has really enriched my professional network, especially in research, and has fostered some really excellent collaborations and a real sense of community in what we're working towards together to improve the outcomes of our patients. So please do make sure to take advantage of that 15% discount that will be available for 2 weeks. So in terms of the schedule for today, I will next hand to Anthony, our president, for the president's address, and then we will have our keynote presentation. We have 2 oral presentations today from Dr. Anuha Gandam and Dr. Andrew Hun, and then we will then go to the awards and closing remarks with our president, Anthony. Over to you, Anthony.
Yeah, many thanks for that overview, Jennifer. Hello, everyone, and welcome to today's ANZSSFR Symposium. As Jen said, we thank you very much for your attendance. I'm not going to talk for too long here today, as I'll be giving a more formal president's address at our AGM, which is following the conclusion of this symposium. So if you're keen to stick around and participate in our AGM later this afternoon, we'd certainly love for you to be involved. But before we do commence, I'd like to extend my sincere thanks to all members of the ANZSSFR EMCR committee for their outstanding dedication and continuous contribution towards society events such as the one that we've got here this afternoon. As a society, we're really fortunate to have continuous support from our EMCR group, who really are the driving force in organising the society's online professional development events. And I would like to particularly thank the EMCR chairperson, Dr. Jennifer Jones, for all of her outstanding leadership and service toward this role. So thank you very much, Jennifer. So I'm really looking forward to this afternoon's symposium, and we're really lucky to have an internationally recognised leader in sarcopenia research in Associate Professor, soon to be Professor, David Scott. He's going to kick us off this afternoon as our keynote speaker. So what I'll do now is I'll hand over to Angela, who I think will be chairing this session.
Thank you, Anthony. And I'm the EMCR committee member and also a research fellow based at Monash Uni. Today I will chair the section and Professor David Scott will present his research on developing recommendations for remotely assessing and managing physical function in older adults. So after the presentation, there will be a 10-minute Q&A section. So please feel free to put down your questions in the chat box or the Q&A box so that I could ask them on your behalf. So without further ado, I'll first introduce our keynote speaker. So our keynote speaker, David Scott, is a NHMRC Emerging Leadership Fellow with the Institute for Physical Activity and Nutrition, IPAN, at Deakin University. His research focuses on the epidemiology, diagnosis and management of sarcopenia and its interaction with obesity and osteoporosis in older adults. He leads several clinical trials of exercise and nutrition for maintaining and improving physical function during aging. And his recent work explores the roles of digital health in supporting older adults to self-manage musculoskeletal health conditions. He has published over 250 journal articles and books and have received over 8 million in competitive research funding. He's also a chair of ANZSSFR's Sarcopenia Diagnosis and Management Task Force and has convened and now lead the Remote Assessment and Management of Physical Function Working Group. So welcome, David Scott, and it's an honor to hand over to you, David.
Thank you for the introduction, Angela. I'll just share my screen. And hopefully that's coming through clearly to you. Yeah, thank you for that introduction. And obviously thanks also to the Society for the invitation to present our work on behalf of the Remote Assessment and Management of Physical Function, or RAMP working group. In terms of the background to why we undertook this process, obviously we know, and many of us here have been involved in work since the COVID-19 pandemic, where we are starting to deliver healthcare via remote methods, which might include digital health applications. Now, we and obviously many others have also conducted a number of studies exploring these approaches for assessing and improving physical function in older adults. And we believe that physical function as an entity might be very well suited to delivery through remote means. Obviously, as many of us know, the diagnosis and treatments for poor physical function can often be somewhat self-managed by older adults, with appropriate support and instruction, of course, but also can be potentially conducted collaboratively with a healthcare professional using a digital health platform. So there's many potential ways in which older people could engage with their health professionals for remote care of physical function, but to date, we really don't know what preferences exist. We also know that the existing digital health tools that we may be using generally haven't been designed or implemented to consider those preferences. So our goal through this process was to develop consensus on preferences for remote care for physical function, both from the perspectives of older adult consumers and also experts working in our field. So to do this, we decided to undertake 2 Delphi processes. And for those unfamiliar with what the Delphi process is, it essentially involves a series of iterative surveys presenting statements that participants rate their level of agreement with. After each round of the survey, the facilitator analyzes the level of agreement for each statement and then presents those findings to the group. And the goal of this is to allow participants to understand the opinions of others in the group, which might encourage them to reconsider their own position and hopefully move the whole group closer towards consensus when those considerations are taken. Now, by way of example, we've previously used this process with some success to develop the ANZSSFR consensus recommendations for sarcopenia, and we undertook both expert and consumer Delphi processes as part of developing those guidelines. So we commenced the RAMP project in 2023 with our consumer Delphi process. The reason we wanted to commence with our consumers is that we felt it was very important that their perspectives would be taken into account when we're later preparing the consensus statements for our experts. We developed the initial consumer Delphi survey in collaboration with 2 consumers to ensure the questions and statements that we included were relevant and clear for the target population, which was adults aged 60 years and older. The round 1 survey included 23 statements, and participants were required to rate their level of agreement with these using an 11-point Likert scale, where a score of 10 would indicate total agreement with the statement. So we presented all of these in an online survey, advertised it via international clinical and research networks, and also via social media posts in late 2023. The data from the round 1 survey we analysed in early 2024 using our predefined acceptance criteria, and specifically a statement was considered to have achieved consensus if it scored, if 80% or more of participants scored it 7 or greater out of 10. Statements with lower levels of agreement were classified as having moderate or low agreement and were analysed by reviewing participants' free text comments about that statement. And then we would revise the statement in some way if we felt there was potential that it might be accepted after taking into account the considerations of the participants. In other cases where the agreement was particularly low, we would reject the statement. The revised statements were presented to consumers in the round 2 survey, and that was early in 2024, along with a document explaining the round 1 survey results and the decisions that were taken in modifying the statements that were presented in round 2. So looking at our participants, you can see that we were able to recruit over 650 respondents with a mean age of 69 years. They represented 15 countries across 6 continents, although you can see that the majority of respondents, were from Australia and the United Kingdom. As we tend to find with our physical function research, there was a predominance of females as well. About 3/4 of respondents were female. We used the SARC-F tool as part of this questionnaire just to get a sense of our respondents' physical function status. The majority were quite well functioning with scores of 0 to 1, although about 30% had scores of 2 or more, indicating presence of some physical limitation. We asked participants about their healthcare experiences, and notably only 1/3 of participants reported having a health professional ask them about their physical function in the past 5 years, whereas 60% had tried to seek information on physical function from a source other than a healthcare professional. Almost 60% had participated in some form of remote healthcare, which I guess reflects the fact that we are seeing older adults being more familiar with digital health, particularly since the COVID-19 pandemic. But in terms of physical function, only about 5% had participated in a remote assessment of their physical function, and less than 1 in 5 had participated in a remote management program, such as a remotely supervised exercise intervention. So it appears that our population was fairly naive when it came to remote physical function care. So we'll take a look at the statement, the round one consumer Delphi statements. There are 23 of these, and obviously it would be quite boring for me to go through each one in detail. So I'll just try to summarize the key findings quite quickly. The first 6 statements assessed the importance of physical function for older adults, and you can see that this was clearly a consensus that it's a health priority for older people. And there was also, it was pleasing to see that there was agreement that physical function can be maintained and can be improved as we age. We also saw agreement that older adults would like more access to information on things they can do to improve their physical function, although it was notable that this seemed to be more so that they could manage it themselves rather than necessarily so they could have more conversations with health professionals about it. Consumers also agreed that it would be safe for them to complete physical function assessments and exercise without direct supervision, but there was poorer agreement on how people would like to engage with remote exercise, including the level of supervision that they would prefer. The participants reported being comfortable using technology to engage with remote care, and they didn't seem to be particularly concerned about privacy or the security of their information. But again, we saw a lower agreement regarding preferences for exercise when we were looking at whether people would like to exercise remotely in a group setting, such as on a Zoom call with other older people joining them, or just participating in individually delivered exercise. So at the end of round one, 13 of 23 statements were accepted to have achieved consensus. 2 round one statements, which were related to concerns around the use of technology or the suitability of people's residences to perform remote care activities, were rejected. And then 8 round one statements that had moderate or low agreement were revised into 7 new statements for round 2. An example of how we modified these statements and how those modifications were presented to the consumers in round 2 is shown on the right of screen. So in this example, round one statements 16, 17 and 18 were statements regarding people's preferences for exercising remotely and whether they would like to always, sometimes or never have supervision from a health professional when they're doing that. And what we found as we analysed the comments of those people who rated these statements quite low in terms of their agreement was that people just have a lot of different preferences for supervision, and also recognise that their preferences for supervision may change over time. And we also recognise that people were probably not really ready to think about whether they need help to improve their physical function if they feel that their physical function is quite good at the present time. So those 3 statements were then modified or consolidated into one statement, which acknowledged the importance of consumers' readiness for behaviour change and also the fact that their preferences would probably change over time. So the round 2 statements, along with the explanations for how they were developed, were shared with the consumers in early 2024, and about 80% of round 1 consumers responded to the round 2 survey. In round 2, 5 of 7 statements were accepted with strong agreement, and these included statements related to having access to more information on physical function for self-monitoring and collaboration with health professionals, as well as willingness to participate in remote tests and exercise interventions. And despite consumers in round 1 feeling confident that they had the necessary resources to participate in remote care, We did see strong agreement in round 2 that having access to appropriate technology and exercise equipment would increase their likelihood of participation in remote exercise. And so at the end of this Delphi process, we concluded with 18 statements that were accepted with strong agreement. And these 18 statements were then consolidated into 7 consumer-informed remote care recommendations. And we've used these recommendations to inform the international expert Delphi process, which we have conducted this year. And you can see that when we commenced the expert Delphi process, we presented the findings from the consumer Delphi in our preamble to the survey. And the hope for this was really, as I said earlier, that experts would take into consideration the opinions of the consumers when deciding on their own perceptions and opinions about remote care for physical function. So the expert process followed a fairly similar protocol to the consumer process. We defined experts as professionals whose work involves or has previously involved supporting older adults to maintain or improve their health. The round 1 survey included 33 statements and was advertised between February and May this year. And the round 2 survey was then shared in July and closed out in August. For the expert process, we had 108 respondents from 16 countries. Again, we saw the majority were female, and again, we saw a predominance of people from Australia and the United Kingdom. The participants were most commonly researchers working in academic settings, although we had also fairly good representation of allied health professionals who were working in healthcare settings. So again, we'll briefly go over the 33 statements included in the round 1 survey. As per the consumer process, we started out with some statements about the importance of physical function. And again, it was pleasing to see that healthcare professionals recognised this as a health priority. Although we only saw moderate agreement on the feasibility of using remote methods for physical function. There was also moderate or low agreement about the time and cost saving benefits of remote care, and also about whether remote care should be offered to all older adults or only those who can't access in-person services. But there was strong agreement that remote care is preferable to offering nothing at all, which again was pleasing to see. There was generally good agreement that remote methods require consideration of privacy and data security. We need development of guidelines, and we need to ensure access and training for technologies for both consumers and healthcare professionals. And then the final statements focused on synchronous versus asynchronous delivery of remote care. So synchronous, I'm sure many of you are aware, refers to live supervised activities, which could be performed either in person in a clinic or remotely. So an example of a remote synchronous activity might include observing a patient performing a sit to stand test at home whilst on a Zoom call with a clinician. Asynchronous refers to unsupervised activities, which might include a patient completing an exercise program at home that has been prescribed to them previously by a physiotherapist, and then the patient is reporting back to the physiotherapist on their progress, which might be done, for example, via a smartphone application. And what we found was that there was only moderate to low agreement that either synchronous or asynchronous methods would be preferable to an in-clinic assessment. And there was generally low agreement that asynchronous approaches could achieve the same outcomes, levels of engagement and safety compared to remote synchronous methods. So at the end of round 1, we had 14 of 33 statements that were accepted. 10 were rejected and 9 were modified into 11 new statements. And as I said, these were presented to experts in July this year, along with a summary of the changes made to the modified statements. A key one that was made was that we used or made use of an umbrella statement. And this reflected our finding in the comments from experts that it was really felt it was very important to specify that older adults should be physically and cognitively capable and also have access to the requisite equipment. So this umbrella statement was then presented before a number of the statements that we presented in round 2. And we had, again, over 80% of our round 1 participants return in round 2 for this expert Delphi. You can see how that umbrella statement is used in these examples here. It sort of is the preamble for each of those statements. And it seemed that with that caveat in place, we were able to achieve strong agreement that remote methods are feasible and can be effectively implemented by healthcare professionals. There was also support for implementing reimbursement policies for remote care, and also for the need for further research on the feasibility and effectiveness of different methods for assessing and managing physical function. So just like for the consumer process, the 19 accepted statements at the end of round 2 were adapted into key messages, of which there were 7. And these are obviously targeted at experts working with older adults. And I think what these statements really highlight is the importance of physical function for older adult health, considerations for accessibility and feasibility of remote care, and obviously the need for development of clinical guidelines, policy, and further research in remote care of physical function. So in terms of the limitations, there are obviously a few. Obviously, as I've mentioned, the surveys were in English only, and we did have a predominance of Australian and UK participants, which may not obviously represent all regions of the world. We were happy to have fairly strong response rates in the second round of both Delphi processes, but it is possible that those lost to follow-up had differing opinions to the rest of the cohort, and the results may therefore be different if we had had responses from those people that were lost to follow-up. Probably most importantly, particularly when it pertains to the consumer process, is that we should acknowledge the selection bias. This was an online survey. It was advertised widely on social media and was no doubt more likely to be accessed by older adults who have fairly good technology familiarity. And so we would expect that potentially they have more favourable views of remote care than perhaps those who are less comfortable with technology. It's maybe a slightly different story with our experts though, because what we found was that only around 30 to 45% of our experts had actual experience of using remote methods to assess or manage physical function. And it was actually quite notable when we did some secondary analyses that there was very much different perceptions for some statements for those with and those without experience. So in round 1, statement 1.07, those with experience of using remote methods had strong agreement that these are feasible. But the statement overall did not achieve consensus because of the much lower agreement of those people who do not have experience. And we saw similar differences in perceptions of whether health professionals can implement remote methods and whether they can be similarly effective to in-person methods. So I think what this probably indicates is that as technology improves, as remote care becomes more ubiquitous, potentially we'll see those opinions shifting more in a favourable direction, where people perhaps start to see that the feasibility and that these things can be potentially effective. So in conclusion, the consumer and expert Delphi processes resulted in consensus on a majority of statements presented. I think overall these demonstrate that physical function is a health priority for older adults. Opportunities to assess and manage it should be made widely available, and that remote care may be a viable option for this where the individuals are capable and organisational support is in place. We hope the recommendations from both processes can inform clinical practice, policy, and future research as well as the development of new consumer-focused platforms to support remote assessment and management of physical function. And to that end, just so people are aware, that the very final stage of the ramp process, at least for now, has actually been a co-design study working with around 40 of the Australian consumer Delphi participants to develop a consumer-informed platform on physical function. And so this process has followed the Double Diamond co-design framework, and over a series of workshops, we've slowly started to develop a prototype website which will allow people to come and learn about physical function, look at ways that they can do their own assessments, and then have conversations with health professionals about their results, and also how to engage with physical function interventions, whether that's doing an online exercise program or being guided towards what physical function services, what exercise services, for instance, might be available in their local area. So we hope we can get some funding for this in the near future to test it in the real world. So with that, thanks again to the Society for the invitation to present. I really would like to acknowledge all of our international collaborators in the RAMP working group, also the people who participated in either the consumer or expert Delphi processes, as well as the funding bodies. And I'll leave on screen the guidelines that we developed, the 7 key messages, so you can digest those more fully. Thank you very much.